Hello everyone, and welcome to a short lecture on glucocorticoids. We're actually going to be talking about a couple different types of steroids during this slide set, but focusing on glucocorticoids. And the reason why is we don't necessarily have a module specific to the immune system. I have some intro topics and things like that. But glucocorticoids are really important for a number of things, especially lots of ENT and pulmonary applications will come up. So I wanted to give a background into their general mechanism here, and we'll really talk about them throughout the entire course sequence because they come up in a lot of different disease states. So just to do a background on steroids, steroids can be broken up into a couple different categories. I think when we think about steroids, a lot of us think about sex hormones, so androgens, estrogens, and progestins. But the ones that are more, well, these have plenty of pharmacologic medicinal roles as well, but what we're going to be talking about more so is the glucocorticoid side. Glucocorticoids bind to a specific glucocorticoid receptor that's really responsible for a lot of immune system related functions. I know that sounds really general, and I'll get into it in a little more detail here in a second, but that's the gist of it. And then there's something in the middle called mineralocorticoids. These mostly interact with receptors responsible for influencing water and salt balance, and they work on the aldosterone system. So almost more in the kidneys, and they almost have more like a diuretic type effect. We'll talk about diuretics during cardiology, but just kind of a totally different thing there. So anyway, steroids have a lot of different functions, and they all are technically in the same class. As you can see, obviously, something like testosterone is quite a bit different than a glucocorticoid we're using to manipulate the immune system. So, but still, they're all pretty much the same, and they're all related. And I told you I don't like structures. Maybe I told you that, maybe I didn't. But anyway, here, I just like to put this on here just to show you guys that there is a combined or a common chain within all steroids. So there's this cholesterol is actually this molecule here. And that's exactly the cholesterol you'd think of, the dietary or synthesized source of cholesterol. And your body ends up processing that through multiple different pathways to make all the hormones you need. So you have all the steroid hormones you need, I should say. So you have aldosterone, corticosterone, cortisol, which is like your primary glucocorticoid. So here's your glucocorticoid, here's your mineral, here's your estrogens, here's your androgens, and here's your progestins. So you have all the different ones, and they're all kind of take steps from each other. So yes, you can't have estrogen without testosterone type derivatives. So they all kind of have to be made and then moved to another one. So the body just manipulates these different side chains until it gets the one it wants. Pretty cool. All right. Glucocorticoids are going to be the focus of this. So talking about cortisol. So cortisol is really the major endogenous glucocorticoid in humans. It's also known as hydrocortisone. That's the pharmaceutical agent. So if you hear the drug name hydrocortisone, that's what we're talking about, cortisol. They're the exact same pharmacologic structure. So if you looked at, like a package insert, the really long thing you get with a drug, if you pulled that open in a cream of hydrocortisone, you'd see that structure there. And that's the exact same structure as what our body makes. We just make it synthetically in a lab and put it in creams and stuff like that, or take it orally. This production is governed by ACTH, and I have a little bit of a little algorithm, not algorithm, it's sort of a flow chart here about how things work here with adrenocorticotropic hormone and how it influences the adrenal cortex and ultimately makes cortisol. Really, cortisol I think of as part of your stress response. It's a natural thing that's released during a flight or fight type response, and it's responsible for a lot of different things in the body. If you have cortisol, a little bit of cortisol is good, a lot of cortisol is bad. It's kind of the rule of thumb, just like with anything really. So if you're constantly exposed to high stress environments, cortisol can take its toll on the body, but it's helpful in small amounts for those stressful periods of time we might go through. All right. So just to talk about this a little bit more, you have the adrenal gland. It sits on top of the kidneys, makes cortisol, and stress-related, whatever it might be in your life, it's going to influence some nerve signals that start in the brain and move down, releasing kind of a chain reaction of hormones, and you're going to get glucocorticoids and mineralocorticoids, along with, on the other side, the sympathetic nervous system, epinephrine and norepinephrine. So you do get both in that flight or fight response. Short-term responses, you're going to see, I'm not going to read all this, but you can see kind of the different things that are created, and then the long-term responses that happen as well with specifically glucocorticoids. So from a pharmacologic perspective, you can see where we're going with this. Steroids ultimately suppress the immune system. Glucocorticoids, sorry, I should stop saying steroids when I don't mean that. I mean glucocorticoids. The problem is that in medicine we use those terms interchangeably almost. So a lot of times when you talk about steroids from a medicinal perspective, that's generally what you're referring to. So if you're like, oh, we need to give them a dose of steroids, usually you're talking about a glucocorticoid. And it's usually to suppress that immune system from overreacting. We use that in a lot of different capacities, whether it's pulmonary medicine or transplant medicine or things like that. So glucocorticoids, again, aka we call them steroids or corticosteroids. It's all the same name. Again, lots of applications out there. They mostly are going to affect cellular immunity, which is not humoral immunity. And so your steroid hormone is going to move through into a specific receptor. So steroids work intracellularly, and glucocorticoids actually work with a glucocorticoid receptor. There's a receptor built in certain cells to interact with cortisol itself. And what's going to happen is that's going to create downregulated pathways, and you're going to get a DNA, mRNA response, creating a new protein, and ultimately that's going to do some different signaling things in the body. Again, high-level stuff, I don't really care as much about those little intracellular details. I care more about just that you understand that it's interacts with cells specific to the immune system. It has a function. It's intracellular as far as binding to a steroid receptor directly. And all of our glucocorticoids do the same thing, even though they're different molecules. So I'll show you some of the other ones that we make that are a little more potent than the endogenous cortisol. And ultimately, what we're trying to do is suppress functions related to allergies, immune-related response, and inflammatory response. And by working with this specific receptor, the glucocorticoid receptor, we can do that specifically. By kind of hijacking the body's natural suppression response, when you normally would do it using cortisol, we can give something that's much more potent than cortisol and really shut the whole thing down. Adverse effects, there's a lot of them. We'll go through them. So hold your horses on that for a second. As far as the anti-inflammatory response, I think this was on another set of slides, so hopefully this looks somewhat familiar. But when we talk about things like anti-inflammatory medications, you might be familiar with the term or have talked about the term NSAID, or non-steroidal anti-inflammatory drug. That's like over-the-counter ibuprofen. And so when you get that type of a medication, the reason why it's called non-steroidal anti-inflammatory is it kind of works in the same area. It has the same effects as a corticosteroid. It just does something slightly different. So corticosteroids, we talked about this, protein expression. What actually would that do? Well, one of the things it can do is down-regulate the production of cyclooxygenase, which is a key component in our inflammatory pathways. NSAIDs work directly on the enzyme itself. Corticosteroids work kind of as a roundabout way to suppress that. So they have that anti-inflammatory property. And then I just wanted to clarify the concept of anti-inflammatory and immune suppression. I think the two kind of get blurred together sometimes, and just they do interact and relate. You're talking about lymphocytes and leukocytes, but there's a little bit of difference there. And where it's interesting is that glucocorticoids kind of play in both sides. They have some effects on both, whereas like a simple NSAID would really only work on this side. And then we have immunosuppressive drugs that don't do the anti-inflammatory component. All right, so the good news about corticosteroids is from a basic perspective, there's only a few drugs you need to know. Now, there's a lot more than that out there. There's a lot of inhaled agents. There's a lot of topical agents we're going to talk about, but we'll get to those when we get to those. The point is, for this particular point, there's not much you need to know from prescribing systemic acting glucocorticoids. So let's just go through this chart quick. You start with hydrocortisone, which again is your synthetic version of the cortisol your body produces naturally. It's got about a 1-to-1 mineralo and glucocorticoid potency. So if you want something that's not mineralo, then you have to shift to some of the different drugs we have that are designed to be much more heavy on the glucose side. There is one drug that I'll point out quickly. I don't care if you know about cortisone. I actually don't think cortisone comes as a U.S. available product. I think you can only really get hydrocortisone. But fludrocortisone it's usually an oral drug. It's used for different types of fluid retention issues and sometimes for orthostatic hypotension as well. It's got some very odd indications. It's not a super common drug, but you can see that that's one that's very specifically designed to be mineralo only. It doesn't really have as much glucopotency, comparatively speaking. And then you've got the drugs we use most often, which are going to be methylprednisolone and methylprednisolone, and prednisolone. I would also, if you're taking notes on here, write prednisone on there, which is just cut out this L and O on here, and then you've got prednisone. Prednisone is pretty much the same thing as prednisolone. So some places use them interchangeably, and I don't know if some countries prefer one or the other. In the U.S., we use prednisone. SONE, prednisone, as our primary oral glucocorticoid of choice. Again, most people who take any type of a steroid burst are going to use that. Most people who are transplant patients are going to be taking that daily. It's our very common go-to oral one. Methylprednisolone does come orally. We just don't use it as much. It does come as this thing called a medrol dose pack, which I'll show you in a second. But otherwise, prednisone is the common one we're going to give orally. Methylprednisolone is one of the more common IV agents we use as a corticosteroid, though. So that's one that is pretty common when you're looking at giving a faster dose of steroid that you want to get in the bloodstream immediately. Triamcinolone is mostly, don't worry about this orally, it does come orally, but it's a very common topical preparation. So again, we'll talk about that during derm. Don't worry about that too much right now. And then long-acting drugs, dexamethasone. Betamethasone is used in some applications. It's more of an oral, and it can only be given IM, so we don't use it very often parenterally. They use it in obstetrics a little bit, but otherwise you don't see it that much. Dexamethasone, on the other hand, or brand name Decadron, is super common, and it's a really potent one. So when you're talking about like the most potent corticosteroid out there, you usually think about dexamethasone when you're giving a dose. But methylprednisolone is also equally effective. It just kind of depends on how you dose it and how much you give. You can always kind of scale up methylpred so that it's going to get the same relative activity of glucocorticoid potency compared to dexamethasone. Comparative dose might be a little bit less. So again, I kind of said all this stuff, but it's listed out here. You've got hydrocortisone, which again is that same molecule. The only time we really use this is systemically available. You can get it as oral, you can get it as parenteral. It's sometimes used in septic shock if like nothing else is working, but it's very, very rarely used and doesn't have a lot of good evidence for it. Basically, the idea is like if your body's been in sepsis state for a long time, you've taxed your adrenal gland's ability to produce cortisol, so you need some replacement, and that's where hydrocortisone comes in. Prednisone, again, this is our go-to oral. A lot of times we use this as a burst or something like that. One thing I'll really highlight with prednisone, just so you guys kind of get this in your mind right off the bat, is with corticosteroids, we're going to talk about the side effects in a couple slides here, but one of the big things about them is that the general concept is if you give them for too long, you end up suppressing the adrenal gland's ability to produce cortisol naturally. So the problem with that is if you withdraw the steroid, your body doesn't really have that capability during a flight or fight response. It takes a few days for the adrenal gland to kind of renew or recharge itself, I guess. I don't know how you want to look at it, but it doesn't work right away. It doesn't produce cortisol right away like it should. This usually takes at least 2 weeks to happen, to have enough suppression to be clinically significant. So for the most part, when you give prednisone, if you're going to give like a burst of steroids to somebody, you can do like a solid week or even up to 2 weeks without needing to taper them off. Some people aren't comfortable with that, and some people like to do little tiny tapers, but really you could give like 20 milligrams of prednisone every day for a week and then stop the person. They're not going to get any adverse effects from that. But again, a lot of tapers will say decrease by certain amounts per day or something like that. But that's really only relevant if you've been on the steroid for a really long time, which does sometimes happen. Talked about methylprednisolone. You've got medrol is the brand name. You'll hear solumedrol as well. Solumedrol is the IV version. Depomedrol is a like oil emulsion version of this drug, and that's used really commonly in intra-articular applications. So for chronic joint pain, they'll give it, and it's something that can be used if somebody is having a lot of pain and maybe is going to get a joint replacement or some surgery or something like that. but isn't tolerating the pain in the meantime. You don't want to get them strung out on opioids, so you try something intra-articular, and it tends to have a pretty good effect that way. And then this is that medrol dose pack. So I kind of dislike medrol dose pack. Well, not kind of. I do dislike medrol dose packs. The reason why is that you have a product that is designed to just be easy for no real reason. So what this is, it's hard to read this. Maybe you can zoom in and see it. But the way it is it gives you a specific schedule on how to take your steroids every day for 1, 2, 3, 4, 5, 6 days. And so it's kind of a self-tapering. Two issues with this. One, if you're taking steroids for 6 days, you do not need to taper. You're not going to get any benefit or side effects from tapering or not tapering. And then two, it spreads it out all throughout the day. So you take like 2 in the morning, 2 at lunch, 2 at dinner, and then you kind of do a different thing the next day. It's like, what's the point? You can take it all at once. So people will be like, oh, I'm starting my medrol dose pack in the evening. What do I do? Just take it all at once. It's fine. It doesn't do anything different. So I don't really understand the point of it, other than it's easy to like write on a prescription. And you can say, oh, I'll just prescribe the medrol dose pack. And then you've got a self-tapering system. Whereas you could just say, yeah, take 20 milligrams of prednisone or 10 milligrams of prednisone every day for 5 or 6 days, and you'll be basically getting the exact same therapeutic benefit. And I've had people challenge me on this before, but I really like to stick to my guns with this one. There is really no clinical point in doing a medrol dose pack other than when you compare it to just prescribing a small burst of prednisone. So anyway, that's my take on it. You can think about that differently. I've had people again who come in and be like, oh, I work in an orthopedics place and we always prescribe those for pain. And like, yeah, you're prescribing the steroid. It works. It's not going to be clinically irrelevant to the patient, but you just don't have to make it that complicated. So anyway, that's all I've got for you on that. Triamcinolone, I talked about having a mostly topical application. I guess I forgot to mention there is also this intra-articular application for it. Again, this is another one in addition to depomedrol or methylprednisolone comes as a suspension. So this is something called kenalog. This is a really common one. So if you're getting intra-articular injections, it's going to be either kenalog or it's going to be depomedrol. It's going to be one of those two products, so triamcinolone or methylpred. And again, triamcinolone is not really used systemically for any reason. It's going to be either a topical application like a cream or an ointment, or it's going to be intra-articular as an injection. And then dexamethasone. So again, this is going to be a really popular choice for both PO and IV use, and just when you need that pure glucocorticoid effect, this is going to be the drug you're going to use in a lot of applications. Specifically, there's a lot of studies out there like in oncology for chemotherapy related immune suppression, and also it works as an antiemetic too, but you're going to see Decadron used very exclusively as the steroid of choice in oncology patients, if that's something you go into. Cons, the only con with it is that the IV onset is not quite as fast as methylprednisolone. So if you're in a situation like in the emergency department and you've got a patient coming in with an asthma exacerbation where they need IV corticosteroids now, you're going to always use methylprednisolone because it's got a faster onset than Decadron. Decadron's not wrong, or dexamethasone, I should say, is not incorrect, but methylprednisolone is the preferred drug in those situations for the most part. All right, side effects, psychiatric side effects, physical side effects are all listed here. The thing to separate out a little bit is acute versus chronic. Acute glucocorticoid side effects are usually going to be more on the psychiatric side. So you could see this stuff acutely. A lot of people actually report that they feel good when they get glucocorticoid injections, so they get kind of a little bit of euphoria. I don't know exactly. I can't personally speak to that. I've never taken them. Once you probably have been taking them for several days, that probably wears off some. But that does happen initially in a lot of patients. It's a relatively common side effect. And they might not get that. They might get the other side of the coin, right? Depression or kind of just emotionally unstable, agitated really easily. Psychosis is really rare, but it's possible, especially with higher doses. The physical stuff is going to be chronic. So this is going to be your patient who's been on prednisone for 20 years because they have a kidney transplant. It's not a guarantee because most of those patients are on pretty low doses to begin with. But the point is that if you're going to see these physical side effects, it's usually going to be from chronic corticosteroids. I do not take credit for these terms, and in fact, these are what is listed as like a side effect. If you go to a drug monograph, I don't think they're very nicely worded, but that's what they're called. So basically, the thing to think about is lipodystrophy. So or a lipo, what's the word? Anyway, distribution of fat. It's incorrect. I'm trying to think of that word and I can't. But you guys get the point. So you end up with deposits of adipose tissue, like in the back of the neck. Where just normal people who aren't on steroids aren't going to get adipose there. You also have rounding of the face that can happen, again, because of the way that the body is distributing lipids differently than somebody who's not on steroids. The other thing that happens a lot with people on steroids is thin, bruised skin. So you can damage and if you cut yourself or scrape yourself, you might bleed a lot more easily or bruise more easily than normal. Decreased muscle mass and increased abdominal fat are also things seen with chronic glucocorticoid use. Again, the higher the dose, and the longer you take it, the more problematic the side effects are likely to be. Okay, so side effects, some more of them. Cell growth and division. So it does inhibit cell division and DNA synthesis. This can delay healing process, can possibly stunt growth in children. Again, this is something that's more long-term that we'd be concerned about. It can have some issues with calcium metabolism, and that can ultimately lead to bone loss and increased risk for osteoporosis, osteopenia. Endocrine hyperglycemia is something that actually can be seen in the acute phase. I have seen patients who if they have regular respiratory issues where they're taking steroid bursts or have done that in the past. I have seen people who exclusively will sometimes go on short-term insulin regimens even because they get so hyperglycemic. So it does have some effect on the way that the body uses glucose, and that can cause a spike in glucose. And if you think about your fight or flight response, again, you want your body to have access to an energy source if you're in a stressful situation, and that's helpful short term. Long term, it can cause issues and it can compound as some sort of a diabetic state. Most people who take short term steroid bursts can avoid this by maybe, again, taking some insulin or something like that during the burst of steroids and then stopping afterwards. But some patients who are chronic steroid users might need to be managed like a diabetic patient. All right, so summary, we have oral options. Again, prednisone and dexamethasone are basically the two oral options. Remember, methylpred is available as that medrol dose pack, which, as you see, I didn't even list over here because I don't like it. There's my bias coming into play again. IV options, you have, again, methylprednisolone and dexamethasone, Potency in increasing order, prednisone, methylpred, dexamethasone, and mineral only fludrocortisone. This is basically what I want you to know for the exam. Kind of have a general idea of the safety. The side effects are interesting and should be known. Just because these are such common drugs, you want to have these side effects pretty well, in your head. You don't have to know every single psychiatric thing I listed, but knowing that psych-related side effects are something that are seen. It's kind of all over the spectrum. Some of the physical stuff. And kind of understanding hyperglycemia and those types of things as well. But having a good handle on, what's your oral option preferred, what IV options are available, and what's your most potent option, and you should be all set when it comes to steroids. So, all right, thanks guys.